heard a lot from Dr. Antonio, and in this afternoon session, we still have 3 more lectures from both of our experts here. So the first session for this afternoon is entitled Cannabis Clinic, McGill University Health Center and Sante Cannabis Prototypes by Associate Professor Antonio Vigano. So please welcome again Associate Professor Antonio. Oh, okay. ขอน้องฝ่ายสดมาช่วยเซตอัพหน่อยนะครับ
Okay, good afternoon. Thank you for joining. I prefer to stand up because I need to move a bit after the lunch, and it's true that it's a lecture where lecture is like you're supposed to read, but I just wanted to entertain a bit a more interactive opportunity so that we can make this a bit more hopefully a bit more fun for you. So this afternoon, my role is really to highlight a way in which we can apply what we discussed this morning, both in terms of research and in terms of clinical innovation to our reality, the clinical reality. And the clinical reality takes place primarily in 2 domains, and that may not be applicable to you yet, but at least in Canada, we have 2 environments. One is the community-based clinic, and the other one is the hospital-based clinic. And you can imagine how different are these 2 environments, and how really we need to talk about 2 sort of different models. Although the patient-driven clinical research and education model remains for both. So again, my disclosure. And again, Chiwaka, maybe Chiwaka is the right name, will tell us that what we want to do this afternoon, or at least will bless our work. One is to describe the Canadian situation. Now, the other one is to see how we implemented this situation, I mean this model in this condition, and obviously we'll look at possible evolution of this model. So, very important to understand that in Canada we have a specific set of rules on how to access medical cannabis. First of all, can only be under prescription or authorization. As I was talking at the table, we call prescription something that you prescribe exactly, how much you have to take, the dose, the times, the regimen, and for how long. Okay, this is a prescription. For medicinal cannabis, we have an authorization, which means the physician has to authorize the patient to consume up to a certain dose, which is measured in dry equivalent of cannabis. So you remember when I presented the data about the Quebec Cannabis Registry, I was presenting the number of grams authorized, okay? And the number of grams authorized in our study cohort, in 3,000 patients, were around 2 grams a day, okay? So that means that patients were authorized to consume up to 2 grams, but they could also consume much less than that, okay? So that is the first thing. The second thing is that the medical document has to be sent to a licensed producer. So in Canada, there are many producers of cannabis, private, okay, but only certain producers are authorized by Health Canada to produce medicinal grade cannabis. Why is that? Because Health Canada will do random checks on these products to make sure that, number one, are free from contaminants. Could be infections, could be heavy metals, could be any other factors that could be a contamination, okay? And second is the concentration of THC and CBD. So by law, this concentration has to be declared, not just for medicinal cannabis, also for recreational cannabis. However, the precision that is required for medicinal cannabis is much higher than what is required for recreational purposes. And you can imagine why, okay? So the variation that you can have in medicinal cannabis in terms of concentration of THC and CBD, which are the two most important cannabinoids, has to be less than 4%. If it goes beyond this 4%, the licensed producer will lose its license. Okay? So that is very important. And the third thing is that the medicinal cannabis cannot be bought on the street, like at a shop, at at a pharmacy. The only way that patient can access this cannabis is delivered directly to them at home, okay, by courier. So that is another important, legislation. Okay, so, oops. Now, this was for Canada as a federation, but at the province level, okay? At the province level, the Collège des Médecins, which is our order of physicians and surgeons, okay, established, once we started, up to last year, that because the cannabis was not a recognized treatment, that it should only be prescribed or authorized, as I mentioned, within a research framework, okay? And so that is number one. So the physician had to keep records of a patient, of the effect, side effects, and potential other aspects that were important. And the other thing that the Collège des Médecins, our order, wanted is that we use Nabilon first, before using natural cannabis. As I mentioned, Nabilon is a synthetic product, is a synthetic analog of THC, and because it was a medication that was already available commercially and also with a specific indication, which was chemotherapy-induced nausea and vomiting. The college wanted physician to try that first. And that was not part of the sort of research protocol. That could have been done before doing the research protocol. And the last thing, sorry. Now, since October of last year, the Collège de Médecins, or the Provincial Order of Physician Surgeons, lifted this requirement of a research protocol, okay, to start natural cannabis. And that was when our registry, the Quebec Cannabis Registry, terminated. So from that point on, we closed the patient recruitment. Okay, in this contest, Sante Cannabis took place, and it would be nice to that things to stay on, but okay, so I would do. So Sante Cannabis took place because it was the only place where patients could be part of a research protocol outside the hospital, okay? So with this opportunity, Sante Cannabis started that patient-driven model for access to cannabis, for research on cannabis, and for training on cannabis, okay? So that is, you know, why Sante Cannabis has become, played an important role in the Quebec contest, and is also where I started myself prescribing cannabis, okay? So I started there learning how to prescribe cannabis. I was doing palliative care back in 2015, but I didn't know about medicinal cannabis until I started working there as one of the physicians, okay? So that led me to do all I did, you know, through that important experience. Again, the model where we have that interaction between patient, clinicians, researchers, and all this take place in the clinic. And all this take place because the work is made out of structural assessment, structural observation, and structural protocols for prescribing medicinal cannabis that we will talk about. Okay, so we have already seen that, you know, this way, this real world data then can feed effectively like a research, a regulatory body, as well as industry for doing collaboration. This is a bit of a snapshot of a 2019 patient population that were seen at Sante Cannabis. As you may appreciate, pain is still one of the most important indications, particularly chronic, non-malignant pain. So anesthetist, you know, a family medicine specialist, all this will be involved in this component. And these were the ones that were referring patients to us because most of the clinicians in Quebec don't know how to use cannabis, okay? About 2% of the physicians in Quebec are really comfortable with cannabis. So again, primary symptom, mental health and insomnia being, you know, very, very important indication. And now, these are the products used. It would be possible to keep that on, because it comes in and out, in and out, in and out. It's difficult for me to, if it's possible. So these are the distribution of the products, and this is a good news for you, because you can see that the THC CBD was really the one mostly used, and will be the one that will be available to you, at least. That is what I know. It could be that maybe you will have just THC. Now, the CBD-rich oil is the second most used. And again, this comes from always trying to choose the safest way to administer cannabis, okay? So you want patients to be functional. You want patients to be safe driving, to do other things. The THC is not friend in this domain. So it's a very difficult, tricky medication to use. So the CBD-rich products is obviously the best way to treat this patient. Now, we're looking at combination, okay, CBD-rich and THC CBD balanced. When we put THC and CBD, we mean balanced products. Products where more or less the concentration of THC is equal to the concentration of CBD, but, you know, is in all products, natural products, there is still some THC in the CBD-rich products, and there is still some CBD in the THC-rich products, okay? So the natural products are never sort of completely pure, but the concentration of the other component is not important if a product is THC. So the other important things to notice is again that we, in almost 70% of the patient, we just use oils. So when patient comes and say, well, doctor, I don't want to smoke. Well, you don't have to smoke. And you probably will, you know, less and less patient will be using inhalation because it's not practical. You know, if you are with other people, if you are, you know, outside your home, start to smoke or to vape cannabis is impossible, okay? So it's good for inpatient, it's good for certain condition, but it's really impractical, okay? But we know that now we have other products that that could be, you know, useful, particularly sprays, okay, and that will mimic a bit the effect of the vaping, will be a bit delayed, you know, as compared to the vaping, but with longer half-life, so with longer. So when you vape or smoke, the effect of cannabis will only last 2 hours, okay? Now, we have patients that use oil plus dry products because the dry products, as we will learn, has a specific indication, okay? But I don't anticipate that because we'll talk more about after. So again, quite good, you know, safety profile. As you can see, most of the patients experience mild side effects, could be drowsiness, dizziness, a bit of feeling a bit high, or feeling a bit nauseous, or feeling, but things that can be very well managed simply by adjusting the dose, okay? And we'll have all this information provided to you. So let's have a look at the effectiveness, okay? So you see the anxiety, very important. You are seeing it. Probably you have it on your, no, that's okay. It's better I look here, exactly. So depression and pain, okay, is two other important symptoms that have, you know, good outcomes, you know, when using cannabis. Again, each patient needs to be assessed at the baseline for whatever for that patient is the indication, okay? So these are the results that we obtained, and particularly in the first follow-up is where we see the main good effects. I will just go by this one. So, there are challenges to this clinical model, okay? First of all, it's a community-based model, okay? In the community, you don't have big control on, you know, on what is, that's perfect. See, it's not going. That's perfect. Thank you very much. So, you know, you don't know exactly, you are seeing this patient on consultation. You don't know a lot about the other medical conditions, how the other medical conditions are treated, because, you know, you are not the attending physician. You know, cannabis can be also seen as a way to, you know, when you don't have any more things to offer the patient, you just offer cannabis. This is obviously a not, you know, purposeful and not a precision medicine approach. There is issue with collaboration with the family doctor. There is issue with, you know, collaborating with the pharmacist, because the pharmacist doesn't know very much about cannabis, and cannabis is not, you know, processed through the pharmacy, so they don't know if a patient is taking or not. You know, we have also issues in terms of patients who comes to the clinic essentially to learn from scratch. So whether for all other medication, they just get a prescription and that's it, for cannabis, they need to be educated. And there are a lot of information to retain. And this is at times difficult and challenging for having, you know, a compliance to medical cannabis. And that is also why we need a follow-up to this patient. So it's not a patient we can write a prescription and see the patient in 6 months. We have to see the patient after 1 month. And we'll see why through also what Virginie will tell us. So now because I work primarily in a hospital setup, so we wanted to translate the Sante Cannabis model into a hospital-based environment, and we wanted that to be integrated within supportive and palliative care. So that kind of treatment was not an alternative to palliative care or supportive care, but was a complement, a complementary assessment. We wanted to do 2 things: implement and verify feasibility of this project. Okay, so not just see if it was working for patient, but also what was in terms of resources. And that could be a good exercise also for the experience here. And so we evaluated a certain dimension. This is a model that we apply in our hospital. So you can see that there is a disease trajectory that starts with the diagnosis, and at times it goes even before the diagnosis. Not really before the diagnosis, but before the treatment starts, okay? So what we call prehabilitation. And it goes all the way through either a restorative intervention for patient survival or to palliative care and bereavement, okay, after the patient death. So, and these are all the programs that we have where we have integrated the medical cannabis program. We are fortunate to have a cancer pain clinic. We are very fortunate to have a psychosocial oncology program, a lymphedema program, an outpatient day hospital. We don't have a home care service. We rely on the home care provided by the government-supported services, and we have a survivorship program. So if you remember when we discussed about how to apply cannabis in the different disease trajectory time, this reflects that model. So how we did this clinic? We set it up to operate 2 afternoons a week. And particularly for physician and for the coordinator of the research coordinator of this clinic. And again, the research concept is always embedded in the clinical model. Okay, that is a patient-centered approach. And we had a nurse, Virginie, who was actually operating 2 full days, okay, because she had to do also follow-ups of patients, and she will tell you what her role, so I'm not anticipating too much. And we were essentially doing monthly follow-up on patients, depending a bit on the need. Sometimes it was just the first month, and then would have been back in 3 months or 6 months. But for patients, we really, particularly the cancer patient, they are not like the chronic pain patients. You know, they have an evolving disease. So we need to have this patient being reassessed frequently. They change treatments. Many things can happen that will require an adjustment of a cannabis. So this was our volumes, okay? And we are reporting now on this initial pilot project of 65 patients. So first of all, what was our principle underpinning our work was that the patient had to be assessed first by a supportive care team, whether it was the consultation team on the wards, whether it was the outpatient, the hospital, whether it was like a cancer patient in the cancer rehabilitation program. We had to have first an optimal palliative and supportive care provision given to the patient. When, despite this, the patient was still symptomatic or was still suboptimal controlled, then the patient was referred to the medical cannabis clinic, of course, if the patient was eligible. If a patient was asking physician to give cannabis to control the cancer, that was not, an indication for a referral to our clinic. If the patient was still, suboptimal control for his symptoms, that could benefit from, let's say, a block, nerve block, or other procedure, that was not the patient that we were going to see right away. Okay. Now, because the patient, we were doing still, we were in the phase where the Collège de Médecins required a research protocol participation, and we were also leading the Quebec Cannabis Registry. We were asking this patient to sign an informed consent to participate. Okay, so very important. That was considered a research project. Okay, so the patient had to sign an informed consent. And then we did our assessment, we proposed our plan, and we'll see how that goes. And then the patient was being followed up over time. Let's see how much time we are. Okay. So, so that was the model. But the most important thing here was that all our work was documented in an electronic medical form. That means that all the history of this patient, why we selected certain products, what were the indications, were really documented along the other forms for the hospital. So this is a bit our results. You can see more or less demographic and clinical characteristics. These patients were fully actively treated oncologically, so we're not dying patients, not terminally ill patients. Important, these patients never come with just one symptom. It's always a combination of many symptoms, physical, psychological, almost as important as the primary symptom. So, this type of treatment refers to my practice. As you can see, first of all, I was fully using Nabilon, okay, in at least half of the patient, along with natural cannabis. But in 50% of the patient, I was only using, natural cannabis. type of product chosen, the CBD-rich one was at least in a little over 50 patients, okay? However, in 22 patients, 22% of patients, I used like a THC-rich, and in 60%, I used like a balanced product, okay, which was THC CBD. So, good news is that when you will have your oil, at least almost 40% of a patient can still benefit from either one-to-one or THC only as products to use. In terms of way of administration, again, the oral route was the most prevalent. We had some patients that were using just inhalation, but a small percentage, and that percentage has been decreasing over time, as the Quebec Cannabis Registry showed. And interestingly, over half of these patients have previously used cannabis. And that is very important, and we'll see why. So here the effect. So we considered change in the ESAs if the patient had at least one unit of change between on the ESAs, and you can see that these patients all improved consistently, okay, and but the best improvement happens at the second follow-up. That to tell you that is really a process. Prescribing cannabis is a process. You are really getting familiar with the patient is getting familiar with cannabis, and there is something that needs to take place and requires time, okay? So that is very important. One thing that I would like you to notice here is what is the category that most improved over time? Well-being. That means that really the way the cannabis work most of the times is improving the feeling of well-being, is the quality of life, is the patient how they sort of cope with the symptoms. I mean, there was certainly some improvement also in the other symptoms, okay, but the well-being and the drowsiness were the most important one. So when we are looking at where the significant change took place, again, well-being, lack of appetite, drowsiness, and tiredness. We were discussing with Professor Shriving about the importance of fatigue in cancer patients, the importance of lack of appetite. There is really nothing that we can use effectively except, psychostimulants in certain conditions, steroids in certain conditions, but really, what seems to respond to cannabis is something that is difficult to treat with conventional approaches. Now the BPI, we have seen how the BPI works, and again, you can see the improvement, of patients at least 30%, and 41% of a patient, in the first follow-up, 50%, experiencing a 30% improvement, okay, so quite something. And the mean BPI score, with interference. Unfortunately, because of a sample size, only the BPI for worse pain was really responding. So the other factor that we wanted to understand is really cannabis helpful to decrease the medication burden? And how to calculate this medication burden? We use the medication quantification score. It's quite an interesting tool which looks at both the weight, they call it the detriment weight for each medication. So each medication has a sort of specific weight that you need to calculate, but primarily for side effects related to this medication. Okay, so that is one information that you have, and the other one is the dose of that medication. Is that, and that allows you to calculate a score. a score for each medication that then you add up for each patient at each follow-up. So, as you can see, in all the follow-ups, we had a change, a decrease in the MQS. However, only in the third follow-up, as you noticed, that also for the symptoms, that decrease were actually significantly, statistically. Now, I think it was, no, it was like a picture that is omitted, but I will try to show it later, where there was some notes taken by a relative about the use of methadone as a breakthrough, and which dramatically decreased after implementing the cannabis oil. So which were the other, other positive aspects that we noticed? First, patients were not referred outside the hospital anymore, were referred to our program, okay? And the information regarding this patient was available to whole hospital professionals. So if a patient was coming to emerge, and was taking cannabis, they knew exactly what and why they were taking. We had an internal medical oversight, and also we favored as Professor Shriving does, we really made, to the whole hospital, publicity about this available service, and, the possibility to also help clinicians to better understand how to work with us and potentially to participate in, in our work. So that has been a bit nothing really important, but to notice that the real work is, as usual, done by the nurse in terms of time commitment, not just time, but also quality of the time dedicated. These are the tasks that were sort of, the time allocated to different tasks. And again, the counseling and the follow-ups by the nurse is very, very important. And for the physician, assessment of a patient were the most important aspects in order to decide also on a treatment plan. Coordination of a clinic, important also to work for the nurses. This was the follow-up that was done by Virginie, and she will tell you more about. Very, very important, to also all the bureaucracy related to cannabis, very, very important, how to adjust the dose and things. So this is a bit of evaluation of our intervention. And I guess we would say that primarily it was a clinic. So again, the access to this clinic was limited to many factors, also availability of time. So it is still a service that is provided not to all patients, but only to a small type of patient, but was patient-centric. It was, again, for equity of access and flexibility, not optimal. Supported integrated care, non-optimal for utilization of nursing time, and we can discuss that a bit more, but it was supporting a safe and quality of care, for patient, and we had specific outcomes that we were looking for, both outcomes and evaluation processes, and it was innovative, certainly, to have that sort of integration within supportive and palliative care. So, vision for the future, We are looking at providing a consultation service model, but we are still basing it primarily on clinic. Obviously, we want to increase participation to clinical trials potentially, and particularly to develop a register in oncology. And further development of education for healthcare providers and the patient and family. So, you know, it's important to know that regulatory systems dictate how this clinic can develop, or these models can develop. Sante Cannabis was instrumental as inspiring our model, and we are still working for both models to improve efficiency and effectiveness. I guess that is it for this part. Thank you.
Thank you very much, Professor. Do you have any questions from our audiences? If you have any questions, you can raise your hand and we will get you the microphone. So maybe if we don't yet have a question for now, we can skip the questions for now and maybe have another. Or does anyone has any comments or anything? We can have a discussion, make this interactive.
Very good.
Okay, so maybe if we don't have some questions for now, maybe we can move on to the next session. So please give another big hand to Professor Antonio. So for the next session, entitled Nurse's Role in Cannabis Clinic, we have with us another expert on medical cannabis, Ms. Virginie Bacis. Ms. Virginie Bacis is a nurse coordinator at McGill University Health Center. She graduated Bachelor of Science of Nursing from France in 2009, and she has then been working at the McGill University Health Center, specializing in the care of oncology patients and palliative care and supportive care. She's an expert in medical cannabis and established the pilot project for creation of the cannabis clinic of McGill University Health Center. Ladies and gentlemen, please welcome Ms. Virginie Bacis.
Thank you. So, hello, and thank you for the warm welcoming, and it's really, I'm really thankful to be here and to share knowledge with you today about my role and medicinal cannabis. So I'm the nurse coordinator at the Medical Cannabis program at the McGill University Health Center. But I'm a pivot nurse in oncology too, and I'm sometimes a nurse at Sante Cannabis, research nurse too. So my disclosure, I have none. So an overview of today's presentation. So an overview of my role in this program. So first, I will discuss my clinic role. So that includes coordination, teaching, file review. So this was already presented by Dr. Vigano. So all my tasks. And that is the evolution of the task, the time allowed to the task. So the coordination. So it was to create at the beginning the project. So there is no clinic. So we work on some forms on how to evaluate the patient. I ensure a triage of the patient, so to make sure that he's a good candidate and to prioritize the new consultation. So I do phone call follow-up too, so some patient, I give my email or a voicemail, so either they can call or email me if they have questions. And this will be the time in the morning I will use for phone call follow-up. So we have a lot of cancellation because we are working in a palliative care. So sometimes the patient is too sick to come to the appointment or dies or anything like that. So I need to make sure that the cancellation is replaced because we have a long waiting list. So to make sure that the time in the clinic allowed to see the patient is full. And for sure I work in a collaboration with the pivot nurse of the patient, the palliative care team, the referring physician if it's the oncologist. So, then I make sure that when they come for follow-up, they have the renewal made for the authorization of cannabis. And so by improving my coordination of the clinic, we were able, first of all, we start to see only 3 patients per day. Now we are able to see up to 6 or 7 patients. So teaching is a big part of my role too in this medical cannabis program. So teaching to patients and families, so to create some protocols and materials. So some oral presentation that I'm doing right now too. Development of innovative knowledge, so I was formed at Sante Cannabis too. And we do, so our team is mainly Dr. Vigano and I, but we have other people coming to visit to the program. And we do some consultation too on the floors. So if the patient wants to continue his cannabis treatment on the floor, or if he wants to start it. So I participate too in the policy for the access to medical cannabis within the hospital. And I'm a resource person. So file review is a big part of my task too. So in the morning, I review and I prepare the note for all the complete medical history, the cancer history. I review the last blood test and the last images for the patient too, the medication that he is taking and if he has allergies. So I make sure if there's possible contraindication, assesses the needs and identify the precaution. I always communicate with the referring physician, pivot nurse, or pharmacist. Then when we start the clinic, I present the case to the team, so Dr. Vigano and some research fellow that we have sometimes. And I ensure precaution for elderly patient or for patient with hepatic or renal dysfunction. So then we do the interview with the patient. So we review all the functional status. How is he doing at home? Is he still working? Is he still driving the patient? So we assess the functional status by the palliative care performance scale and the ECOG. So we review to the mental states, if the patient have suicidal thoughts. How is he surrounded? Is he well supported at home? History of abuse that we have to review too. And we review all the medicine that the patient is taking. How is he taking them, if he has some side effect, and at least that he has tried the first and second line treatment before starting medical cannabis. So we review the history of cannabis use, either for medical purposes or recreational purposes. So that's a big part too of the assessment. So how often he is using cannabis or was using cannabis in the past, if he had some side effect or some benefits, and does he have a history of cannabis use disorder or cannabis addiction or addiction to other drugs too. So we warn the patient of the possible side effect and risk factors. And so in Canada, one of the big problems is the financial means, because the patient has to buy the cannabis himself. So we will review the price, but it's an expensive treatment, and it's not covered by the governmental plan, or some private insurance has started to reimburse, but on a rare case. So some of the licensed producers give a discount to the patient, but it's minimal. It's still difficult, so it's a big burden, the financial. So then with the patient, when we have assessed all the symptoms, the history of use of cannabis, we review if he has any contraindication, potential contraindication, and then we set some objectives. So the objectives can be the symptom control. So for anxiety, pain, insomnia, anorexia, and plenty of other symptoms. Some patient wants to increase their performance status, so they want to go back to physical activities that they were able to do. That can be an objective too. Maintenance of the autonomy or better mobility. Weight gain or maintenance, and appetite stimulation. So some patients come to decrease the use of certain medication. So they want to decrease the opioids or some other medication that they are using because of a side effect, or those limiting the side effects. So at each appointment, we use ISAS and BPI that Dr. Vigano reviewed already. And this is used to monitor the progress and to collect data. So then we go to the treatment agreement. So what needs to make very clear with the patient is that they need to understand that the medical cannabis is not recognized as a medication yet in Canada, They cannot travel with it, so they cannot cross any border. They can travel through Canada only. Make sure that the patient understands the objectives, and that the cannabis will be used as a complementary treatment with all the other either medication or approach that he is using, and it will not be an alternative treatment, so always a complementary treatment. And so to stay in contact with the clinic and to disclose the side effects. And we review the objectives over time and expectation for cannabis treatment. So then the other role is the treatment plan. So we review, after the interview with the patient, we go back in our office and we review what was said and what are the objectives. And we set a treatment plan as a team. So we review everything. Then we always follow the rule to, when we start a treatment, to start low, go up slow, and stay at the lowest dose possible. Then when the treatment plan is done, my other role is the patient education. So that is a big part of my task too. So when the treatment plan is set, so the nurse will review how to take the cannabis and teach the patient really how to dose himself the cannabis, how to use the syringe, and how to administer it. And we review some general information too that I will go over with you, so with the patient, the difference between THC, CBD, between synthetic and natural cannabis, and some pharmacodynamic and kinetic. So we go over the registration with the licensed producer. We explain that there's a delay. They are registered with the producer, then it's at least a week for them to be contacted by the licensed producer to say that their file is open and now they can order the medical cannabis. We review the law, Quebec law, to access to cannabis. The allowance, so as Dr. Vigano was explaining, we give an allowance to buy the cannabis as a maximum of equivalent of dried cannabis per day. So that is explained to the patient. So usually, to start, we prescribe 1 gram per day, so a total of 30 grams per month. So usually, they can purchase 3 bottles of cannabis oil a month. So they can have at home 3 bottles. So the teaching part too is what to do if I have a side effect. So how can I manage it at home? And they will have to call me or send me an email to explain to me what happened and what was the side effect. So the different routes of and options to take cannabis that I review with the patient. So dried cannabis, the flower of cannabis can be used in joints. It's really rare. Usually we encourage vaporization, so to use a dispositif that only heated the cannabis, not burn it. The cannabis oils bottles, so we have 3 different types of oils available in Canada. So CBD-rich oils, THC-rich oils, and 1-to-1 ratio oils. So we start to use topical application of cannabis. We have some recipe for them to make their own cream of cannabis. So if it's localized the pain, for example, to the shoulder, or they can use it topically if they have problem to tolerate it by mouth, for example. And we have sprays of cannabis, suppositories, and soft gel. So in the treatment option, we discuss, the patient and I, the difference between the THC and the CBD. This is explained, and this is handed to the patient too. So the THC it's intoxicating and impairing, but it's a good analgesic, anti-emetic, good for appetite stimulation too. And so what is the problem with THC is that it's biphasic. So for anxiety, for example, a little dose can be very good, but if you go a little bit too much, and this is the opposite, you have more anxiety. And for the sleep aid too. So it can be a good sleep aid or too stimulated or stimulation. And so the CBD is the easiest and safest, so non-intoxicating, and it has plenty of benefits. So it's the safest and the easiest that can target plenty of symptoms. So that's why we usually start with CBD. So really rapidly, we review with the patient the pharmacokinetic of cannabis. So inhalation is like an as-needed dose of opioids. So it's act fast and go out fast of the system. So it's to use as needed for like a breakthrough pain or anxiety. So it's really rapid. And then go out the effect within 2 hours. For an oil and edibles, when it's ingested, so it takes 1 or 2 hours to have his level of efficacy, and then stay at a plateau for 6 to 8 hours. When they use sublingual, like sprays, it's the mix of the two. And the rectal is like an oral preparation. And it can have a local effect to the rectal administration. So the treatment option, what we call so the chemova that we review, the possible of THC-rich, THC CBD or CBD, the cultivars, so sativa, indica, or hybrid. The posology, so the dried cannabis, we will speak in percentage of THC and CBD. For the oil, we will speak in milligram per milliliter. And for a capsule, we will speak in milligram per capsule. And for a spray, in milligram per milliliter. So the price, they are very expensive. So with the patient too, during the teaching session, we review the side effects. And what is important here to keep in mind is like for each person, the side effect with the same product can be different because our endocannabinoid system is different. So this is an overview of what I review with you, of what I teach to the patient. So the side effect, then we go over the titration too. So this I will present tomorrow, all the titration, how is it done. So usually, depending on the symptoms of the patient, either is to take at at night, or twice a day, morning and night, or morning beginning of afternoon, or 3 times per day, if it's an ongoing symptom. So they start at the lowest dose possible. So usually we speak about 5 milligrams of CBD to start, and 1.25 to 2.5 milligrams of THC. So usually they start, for example, at bedtime for 3 days, then twice a day for 3 days, the same dose. Then they slowly increase the dose every 3 days. So this I give a table to the patient that they can follow. So I explain to them all the titration, what and how to proceed. Promote treatment compliance, promote autonomy, and so the legal matters that I told you already. Then another role is the follow-up. So usually we are trying to see the patient within a month after starting his medical cannabis. So at the follow-up, the team goes to see the patient complete the ESAS and the BPI questionnaires. We review this questionnaire and see if some objective or scores are going better, if the patient is responding to the treatment. And we review with the patient so what the oil that he has started or any kind of cannabis. So what he is taking right now, and how was the titration, if he had some side effect, if he had benefit. We update the medication list, and we review too if there were any change in the medical situation since the last visit. So we review if they have new images, for example, of if anything has changed in their condition since the last visit, and that we document everything. We review again the titration. We give some help to the patient that, for example, if the symptoms, I'm good during the day for my dose, but at night I'm still having trouble to sleep, so we encourage them that they can increase only the dose at night, for example. So to evaluate the readjustment in the dose, the frequency sometimes, and some objectives. Then after that, usually we see the patient every 3 months. If they are stable, we can go to every 6 months. And some patients will still continue to have regular follow-up, like every month. So at Sante Cannabis, the research role of the nurses, so and my role too in the medical cannabis program at the hospital, it's more to enter the data, so all the notes and the chart reviewed that I told you. So at Sante Cannabis, the research nurse will get the blood sample, take the patient vital sign. She helped the patient to fill the questionnaire. They have some protocols, so they follow the patient within the time for the protocol, and they collect a report for all adverse events. So I think I was a little bit fast. Any question or comment or?
Okay. Are there any questions from the audience? Thank you very much for this very detailed presentation and this. So if anyone has any questions for Ms. Virginie, please raise your hand. Yes, please, Professor Somdet.
Happy New Year, Dr. Bacis.
Happy New Year.
You have a very wonderful presentation.
Thank you.
However, this today is quite academic. I hope that sometime we will have a recreation cannabis that we can enjoy something and sing a song together. My question is that do you have how many percentage of withdrawal or absentee from this long-term treatment and the reason why? Thank you.
So, how many? I think you asked for a number. How many patients? I'm not sure. Can.
อาจารย์ถามเรื่อง absentee ใช่ไหมครับ
The withdrawal and absentee and the reason why they are absent. They don't like you or because of the toxicity happened to them or whatever. Thank you.
Okay, so yeah, sorry. Thank you for this question. So sometimes the patient gets sicker because we see patients in palliative care. So either they are hospitalized, then they stop the medical cannabis. Sometimes it's the financial means. And some frail patients that are already sick, as soon as they get even a mild side effect, it's discouraging. They want to let it go because it was something that they didn't like, the side effect. So, yes. And even in the palliative care, the hospital or cancer pain clinic or cancer rehab program that we have a lot of cancellation of appointments. Yeah, because the patients are quite sick. And yes. Thank you for the question.
We have another question.
So thank you for a very good presentation. Seems like you are the first one who screening for medical cannabis usage, right? Because you said every consultation gonna pass and screening by you. So what is your indication for include the patients who to be receive the medical cannabis?
It's noisy, I think. Did you understand that? Yes, thank you. Very good question. So mostly the contraindication are for THC, so active cardiac problem, cardiac disease, active heart problem, because THC can increase the tachycardia. So this is a contraindication to start cannabis. Usually, Health Canada said during pregnancy, this is or breastfeeding, to start cannabis. It's a contraindication, but we always see the benefit and the risk that the patient is taking to start cannabis. So we will see that a contraindication will be an history of psychosis or schizophrenia in the first degree relatives. So heart problem. For liver dysfunction, because the cannabis is metabolized through the liver, it's just that we use lower dose and less frequently, only once a day, and to titrate very slowly. And so the contraindication for active lung problem, lung disease, is more to not smoke cannabis. This is because it can increase the lung problem. Yes, and this I will present that tomorrow. Is there anything that you want to? Thank you.
Okay, so please give another big applause to Ms. Virginie. Thank you very much. Great.